Does the recording help?
Sir, irreversible neurosurgical insult.
Go on then. I'm listening. What's the definition of cerebral palsy?
Sir, irreversible neurosurgical insult to the brain.
Yeah, it is not a simple definition. It's an umbrella of features. A lot of things put together is called cerebral palsy. Yeah, so it's not just one thing. There are problems at different levels, mostly congenital, before birth, and some during birth. But it's a constellation of symptoms put together. Is cerebral palsy. So it's not just one disorder. Therefore, it isn't a perfect definition. So, do you know who first coined the term cerebral palsy? So the guy called William John Little, okay? And that's why cerebral palsy is also called Little's disease. Okay, so if somebody asks you about Little's disease, that's cerebral palsy also. Okay, so it was a general surgeon, orthopedic surgeon in 1861, and he described cerebral palsy. And what he was describing was it was a condition of marked incoordination of muscles, and it was typically caused by the brain damage. Like I used and said before, it's an umbrella condition. There's a lot of things combined together, and we put in the name of cerebral palsy. Everything does not fit into everything else, but we're going to have a classification to try to make it simple. Like, okay, so it is a motor function disorder, and it is caused by birth lesion, and it is non-curable. It is lifelong, and it doesn't worsen, but it is the response of the problem that causes you deformity worsening. So the disease itself does not worsen, or the pathology doesn't worsen, but it's the consequences where the muscles are not working, which gives you problems long term. Okay. So when you see a patient with a cerebral palsy, you have to take a brief history of birth, because most of these are difficult labors. They are twins, or they have breech presentations, or they have some sort of infection that mom had, or some sort of problem which causes the brain itself. Okay, and in the history, parents will tell you that they have an abnormal gait, they have some deformities, there's some stiffness, the mental status does not develop normally, and the milestones are very, very delayed in development. Okay, so if you look at this slide, this is just to remind you. If you look at this picture, a normal baby, if you hold it, will move all his legs and it will have a posture. A cerebral palsy child will be floppy. If you lift it, it cannot do anything at all. If you sit a child, it will have tone, whereas a cerebral palsy person will have no tone. A child who's normal will play with things around it. A cerebral palsy child will ignore everything. Sometimes if you put a cerebral palsy child flat, it will go into a stiff back position. Occasionally, they will not respond to toys and noise. Okay, so toys and noise they don't respond to. Depending on the type of symptoms they have and the type of pathology they have, they may have, instead of being floppy, a scissor type of gait, and that's from the adduction, deformity, and tightness of the muscle. And if you twist their heads to one side, they will actually raise their hand up off that side. That's a reflex. It's an inborn reflex. It's got nothing to do with the pathology. Okay, and if you press their shoulders and head back, they actually go into a spasmodic type of effect. Okay. So when you classify them, there is a functional classification, a geographical classification, a physiological classification, and sometimes there is deformity that we have to describe. Okay, so do you know what a functional classification for these would be? Does anybody know? Do you remember this is a community ambulator, this is a full ambulator? Remember?
Yes, sir. This is a GMFC classification.
Yeah. What's a GMFC? What is it called? What does that mean?
Gross motor function.
Fantastic. Okay. So you have basically 4 classes in them. The ones that have got no limitation of activity. There are ones who have got slight limitation. There are ones who have moderate limitation. And there are ones which have got no useful activity at all. If you classify them, this is what we use in England. He's independent, which means he can do everything. He's a community ambulator, which means he can go around the community and ambulate, either walking with a scissors gait or with some orthotics or with some wheelchair. Then there are community ambulators with help, and there are home ambulators with help, which means that they can go around the house only just about. And then there are non-ambulators. The non-ambulators are the worst type, okay? So if you look at them, this gentleman has got cerebral palsy. How do you know he's got cerebral palsy? Because he's holding his hand flexed and his elbow flexed, isn't it? So yes, so he is a level 1 because he's walking perfectly well. The level 2 has got some flexion contractures around the knee, but is still walking without help. Then you have the level 3 ones where they have some sort of orthotics to help them. Then there are wheelchair bound, and then there are children that can't do anything at all, and they have to mobilize in automatic electric chairs and stuff like that. Okay, so the geographical classification is whether they are fully mobile, they are ambulators with help, they are social ambulators or community ambulators, and they're non-ambulators. Okay, so if somebody asks you in the exam about the classification, you would know this now. Okay, this is simple and easy to remember. Good. So then you classify them according to geography, depending on which part of the limb is involved. So they are monoplegic, hemiplegic, diplegic, quadriplegic. Okay, and the rarest type is the monoplegic, i.e. one limb, or triplegic, where they have 3 limbs involved. But the hemi and the diplegic and the quadriplegics are the commonest types. Okay, so basically you have either one side involved, you have either upper limb or lower limb involved, or the whole body involved. That's the commonest types. Okay, but the rare types are when 3 parts or triplegia is there, or monoplegia, only one type is involved. Yeah, so these are rare types, but it's a symmetrical disorder where you have bi, di, quadra as common causes. Yeah. So then physiologically, you classify them into spastic, athetoid, coriform, ataxic, rigid, and mixed. Okay, so the reason there is so many types is because the pathology is different. I'll show you a slide in a minute. Okay, but remember this: they're either rigid, totally spastic. What's athetoid? What does the athetoid type tell you?
These are the
involuntary movements.
Okay, and coriform?
Involuntary uncontrollable movements.
Repeating unbreathing movements in coriform.
Okay, and what about the ataxic?
There are gait problems in ataxic.
Yeah, what, sorry?
Cerebellar.
Gait
Balance
problems.
and gait problems.
Yes, they have a broad-based gait. Okay, so these are the main classification. All right. So what it says is the reason there are so many different types is because the pathology is different. So
Yes.
if the cerebral area is involved, they're ataxic. Okay. If the pyramidal system is involved, they're spastic. And if the basal ganglia is involved, then it ends up into various other disorders. So that's why it is an umbrella of constitution of symptoms. It's not one disorder. It is various insults that the brain has had during pregnancy, which results in cerebral palsy. So cerebral palsy by itself is not a condition, but an umbrella of symptoms that put together, we call them cerebral palsy. Okay, is that clear? Where the pathology is, it will depend on the type of abnormality. So if they are spastic, then the pyramidal system is gone. If they have got ataxia, then the cerebral system is gone. And if they have various other combinations, then the basal ganglia is involved. Okay, so but it's not one problem. It can be a combination, but it is different levels of the brains will cause you these problems. Okay, so let's talk to them. Let's talk about them individually just to understand, so that you don't get confused in the exam. So you've already said to me the spastic CP, okay, and it is the 80% of all the cerebral palsies you're going to see. I'll be pictures shown of them. They are tense. They have contracted muscles, and they have stiff and jerky movements when they walk because of the spasticity. They don't have the gait is the important thing. We'll come to it. But when they walk, the hip does not go where it should be, the knee does not go where it should be, and the foot does not go where it should be. Therefore, they have a problem in walking, and they have this spastic gait. Okay, and the reason of the spastic gait is because the muscles are tense and anatomy is not normal. Do you know why heel contact was changed into initial contact? Do you know why this was done?
So can you repeat it?
So when you look at the gait, we all used to remember reading them. At least I remember these. It used to be heel strike. But now the heel strike has been taken off the system, and we call it initial contact. So why is that classification or pathology changed? It is because of cerebral palsy. Okay.
Yeah, because there is no heel strike in CP patients.
Yeah, that is why the classification was changed, or the terminology was changed in gait, because otherwise you could not do a gait analysis on a cerebral palsy patient. That is why the terminology was changed. So the commonest type that you will be seeing is the spastic type. This is a typical picture. It is a hemiplegic one, isn't it? One side is gone. the elbow is flexed, the hand is also flexed, and they are all stiff from the hip below. Like, okay, they walk with a very awkward and very, very jerky and very stiff gait. Okay, it is called a spastic gait. We'll go through it later on, but that is a spastic type of the CPs. Okay, athetoid type are dyskinetic. Okay, and they have involuntary movements. These movements disappear when they sleep. And if they're speaking or feeding or grabbing, these movements are increasing, especially with stress. Okay, this is the second commonest type of cerebral palsy we'll see. It is only 20% of all cerebral palsy, but it is the second commonest. So the commonest one was a spastic. Then you have the athetoid ones. They have abnormal involuntary movements. The key here is that they disappear during sleep and they increase with stress. So if you're feeding them, you're talking to them, you're saying anything to them, their movements actually increase quite a lot, and that's causing them either stress or they are listening to you or they're responding. So the athetosis by definition means that you have worm-like movement in the hand. It is totally uncontrolled, okay? And it is mostly in the face and sometimes in the extremities. If you see these patients for a long time sitting doing something, they will end up with dystonia, which means they have no expressions at all, and that's because the muscles have now gone. What's the word? They have actually burnt out in function. So they've used all their glucose, and they have got no more function left. So for a little while, unless you rest them, they will have dystonic faces purely because the athetosis does not disappear. It's just the muscles have exhausted. Okay. So again, dyskinesia is basically these people can't talk, and it's because of the adductor spasm. All the legs comes together, right? Same thing completely. Just to make sure that you understand that when they're stressed, they actually get excited, and all these movements get exaggerated. Okay. Then there is ataxic CP. Okay, this is very uncommon, and these patients have no balance at all, and they walk with a broad-based gait. Okay. So what's the difference between a gait in a child and an adult? Do you know?
No, sir.
So the children are already broad-based anyway. They don't walk with a normal gait as an adult does. And you don't get an adult gait until you're 14 years old. So they're walking with their feet apart. And that's to keep their balance, right? So they are apart. But in an ataxic cerebral child, his gait is even more broad-based than the normal child, purely because he's trying to keep his balance. So he walks with very, very abducted feet, like, okay? And the big thing with these things is that if you assess them, they cannot walk in a straight line. Okay, they may walk, but they can't walk in a straight line. So the ataxic CP classically don't walk in a straight line. So if you draw a straight line, remember the Stahili profile when you ask them to walk in a straight line. If you ask a child with ataxia cerebral palsy and you ask them to walk, they cannot walk the straight line. Okay, so you must all remember that nature is very kind. So most of the time, he will give you mild to moderate CP, which means you can help them. They have a life and assistance, but they're not totally impaired. Only a few people have severe CP. I'm not sure what happens in Pakistan, but in this country, they're a total nightmare. They're too expensive to manage. They have special nursing care, nursing needs, and special instrumentation to give them. However, the state looks after them, and they're all looked at. And they have electric chairs and electric beds and nurses that go in and see them, and social services that look after them. So they have visitation every day, every week, every month, or depending on their needs. What happens to people in cerebral palsy in Pakistan? Do you have an idea? I don't know, but you can educate me. So what do we do with people in cerebral palsy in Pakistan? We leave them to die, is it? Have you ever seen a cerebral palsy patient in Pakistan?
Yes, sir. We have seen the cases. We treat them, and our
what types do you see?
most of the cases moderate cases that we see in our
soft
clinic.
tissue correcting and surgery for soft tissues, yeah?
Yes, sir.
Yeah, so you don't see the severe CP ones.
Less likely. We mostly see the moderate cases, sir.
Okay, because in our pediatrics rotation, when we do pediatrics for 6 months when we're SPRs, we end up seeing quite a lot of the severe ones. So it's a very depressing situation, and there's a very high volume input they need for them to be normal, but the state does not forgive them, and they actually help them out. So like I said, it's an umbrella of symptoms which is called CP. So they have abnormal tones, their strength is weak, they have abnormal reflexes, they have persistent motor delays, they cannot recognize, they have handicaps, their balance is not right, and they have loss of control of coordination, and the tone is either flaccid or exaggerated. So all that together, if you find, is called CP. And the reason for that is we've already seen that it is not one pathology that causes a problem. There are various pathologies in the brain that has problem that causes CP. Okay. So Gait. I will go with Gait later. I just bring it here for just reference. We'll talk about Gait after we finish CP. Yeah? So to have a normal gait, you have to have normal bones, normal joints, normal muscles, normal nerves, and normal balancing. So anything goes wrong, your gait will go wrong. And the magic is that when you analyze the gait, you can look at it, you can find out what's wrong, and then you can see what you can do about it, okay? So, like I said, in children, the base is wider anyway. There is no heel strike up to 2 years. So initial contact is made with a flat foot. This is normal, this is not abnormal. And the stride length and velocity is less. We'll talk about stride length and velocity, but does anybody know what the stride length and the velocity is?
Yeah.
Does anybody?
Yes, sir.
Nobody wants to play. So what's a stride length? Okay, we'll come down to it. It's a difficult topic. We just want you to know that you can talk yourself through in the exam, okay? So the knee flexion in stance phase until 2 years is also reduced, and there is no swinging of the arms until 4 years. Remember these things. Okay, the base is wider to 4 years. They don't have a heel strike. They have a flat foot strike up to 2 years. That's normal, okay? And they have shorter strides, so therefore they take longer to get where in dogwood because their stride is longer, and their normal velocity is less purely because they're shorter people, like, okay? And they don't have an arm swing until 4 years. Okay? These are things you need to remember. So if you see somebody who is less than 4 years and has no arm swing, don't label him as cerebral palsy because that's normal. Okay? So we will come to it, but there is a stance phase and a swing phase, and stance phase is how much of swing phase?
Stance phase comprises of 60%, and the swing phase comprises of 40%.
So that's correct, but not completely correct. What do you have to add to it?
We knew it.
When you are walking normally, correct? So if you're running, you don't have 60% of stance phase and 40% of swing phase, isn't it? It is the other way around.
Right.
Yes.
If you're running, it's 60% of swing phase and 40% of stance phase, isn't it? So when you're walking, the stance phase is 60% and 40% of stance. But when you're running, it becomes totally opposite. Like, okay.
Okay.
So these are the things you have to remember. So what is a step length? It is a length between the 2 feet when you have both feet on the ground. Okay?
Right.
So the stride length is a distance when the limb travels in the swing phase. And step time is the time needed to complete one step. And cadence is number of steps per minute. And walking velocity is distance traveled per time. These are things that you need to know before you talk about gait. Okay, we'll come back to it again, but remember, these are the 4 or 5 things that somebody can ask you in the gait. Right? Everybody gets asked, what is stance phase, what is swing phase? So I have had, well, I was in trouble a few times when I said, well, that's not correct. And everybody started telling me in this book it's written this. It's true, but it says walking. If you're running, it's totally opposite, isn't it? So it will make a lot of sense if you tell the examiner in normal walking, the stance phase is 60% and the swing phase is 40%. So that the examiner knows that you know that if you're running, it'll be totally different. You must know what is a step length, what is a stride length, what is a step time, what is cadence, and what is walking velocity. You will have this video later on. You can have a look at it, but you must remember these by heart. There is no other way to remember just by remembering by heart, okay? Okay, so this is what we do in our country here. We actually have these glass beads that are attached to children when they're walking with cerebral palsy. And there is a machine that measures them, and that's how we measure gait. So gait is not only walking, but it measures all the muscles acting all around the body. And if they are on a wheelchair or a frame, they are allowed to use the frame, but the same thing is measured again. So these are small dots it's like, you know, when you're doing, do you guys in Pakistan do the navigated knees and like navigated hips?
Gait laboratory test.
Sorry?
Gait laboratory test.
I can't hear you. I can't hear you at all.
Sir, he's telling about Gait laboratory test.
Yes. This is the Gait laboratory test. You need to know what muscles are moving and not moving. You know, walking is different, but this is the whole thing together. Right, so when you're doing a navigation knee, you put those glass markers on the knee, and then you have a computer that tells you where everything is. This is exactly the same principle, but applied in a big room rather than just in a knee. Okay, so we know about this. The reason I put this in there is that if you have that special type of cerebral palsy, then they don't walk in a straight line. Okay, so what type of pathological gait do we now have in neuromuscular conditions such as cerebral palsy? Well, they have either a spastic gait where they're equinus, where the foot has gone into varus, where they're trying to bend their knees. So because the knees are being bent, then the ankle responds to it. And when they have got a crouching gait or the stiff knee gait, you must remember to identify the pathology. Okay, if you have an equinus gait, does not mean it's the heel problem. It may be that because the knee is flexed or the hip is flexed, and the ankle is going into a pointy position to allow you to walk normally. Okay, so this is key. In cerebral palsy, you have to identify where the problem is before you do any surgery onto them, because if you do the wrong procedure, such as the person is walking with a bent knee and you think it's got an equinus problem, and you do tendon Achilles lengthen, you've actually made it worse rather than made it better. So you need to very clearly identify where the problem is before you can sort it out. So there was a pediatric surgeon, Salter Harris, a guy who described the Salter osteotomy. He used to call surgeons who did not know pediatrics as birthday surgeons. Do you know what that means? For cerebral palsy patients, they used to have called birthday surgeons.
Sir, on each hand, one surgery is
Sorry?
Surgery.
I can't hear you guys. You got your mics too.
So what they do surgeries at multiple times, and every time they do a separate, they do one time hip surgery and the other time they do knee surgery.
Yeah, okay.
And
so that is not correct method to go. You're absolutely right what you just said. Birthday surgery, they have one correction every year. Okay, in palsy patient, cerebral palsy patient, for them to benefit, you should find the pathology and then address it at the same time, rather doing bits in every year, because every time you come back, there's a year gone by, and the muscle imbalance has actually made it worse. Remember, we were talking about rheumatoid. The deformity is purely because what is working and what is not working. So you've got something not working and you correct it, and then you wait a year to come back again, the deformity is totally changed. So they should have diagnosis done straight away, a pathology is recognized, and everything done on the same sitting, not at multiple levels. Therefore, cerebral palsy was known to have birthday surgeries. Every year they used to have a procedure, but that is now gone. Everything has to be checked, assessed, a gait analysis done, and then one procedure done completely. Okay, so let's look at the deformities in general. Okay, so when you are walking, what you're doing is the center of action on the hip is allowing you to do various things. Now, this is a straight leg gaze. This is the problem when you have tight hamstrings, and this is the problem when you have flat feet. Okay, so we take them individually. This person is walking with a equinus deformity, so we need to know very carefully that the deformity is in the ankle or is in the knee. So if the knee is flexed, to get the height correct, you will have an equinus deformity. However, if you have an equinus deformity, you have a flexed knee also, because your leg is longer. Do you understand? So you need to know whether the problem is at the knee or the problem is at the heel. And the way to test them is to take the knee out of function totally. So if you flex the knee and you still have persistent deformity, then the problem is at the ankle. If you flex the knee and the deformity gets worse, then the problem is at the knee. Did you understand that? Yeah, you need to isolate where the problem is.
Yes, sir.
Are you with me? You see, you can have a long leg because you have an equinus gait, so the knee has to flex. So the problem is the equinus, not the knee. However, if you have tight hamstrings, the knee will flex, and therefore the person will have a short leg, and to get to where he wants to, he'll have an equinus part in his leg for him to walk. So the problem can be either at the knee or the heel, and you have to isolate the problem. So if the problem is at the knee and you do a tendon Achilles lengthening, you make it worse. If the problem is at the heel, but you do a hamstring release, then you make it worse. Do you get that? Yeah, it is simple, but you need to know where and isolate where the problem is. Okay, so it's the same thing explained here. here, in this particular picture, you have equinus because you have a tight hamstring. Okay, and if you, instead of the tight hamstring, you release the Achilles tendon, the deformity is going to get worse. Okay, because now the patient has got a tight knee, but his equinus was compensating for it. You made the Achilles tendon go, and now he can't even do a equinus. So he has now got a short leg deformity because the heel has gone flat. Okay, so you need to assess the pathology where the problem is before you do the surgical procedure. It is a straightforward, simple thing, and don't complicate it. I'm just making it a bit difficult for you, but you have to understand that you need to isolate where the problem is. The gait analysis will help you, but the clinical analysis will also help you. So if you have a person like that, okay, how would you know that the hamstrings are tight or the Achilles tendon is a problem? Is there a test you can do?
Yes. Silver slide.
Is what, sorry?
Silver stable test.
So how will you test if the hamstrings is tight or not?
Thompson test. Thomas.
No. Thomas big specs are different.
Yeah, yes.
The knee reflexes.
So what you're going to do is you're going to leave the person sitting on the table with the knee hanging, okay? So if you extend the knee, the person will flex his back because it is attached to his
Tripod sign.
Is what, sorry?
Tripod sign.
I don't know the name for it because I've had this habit of not remembering name, but I don't remember that name what you're saying it is. It's also basically sit them at the edge of the bed, and if you extend the knee, the hip will extend. But if the hamstring is not the problem, it will make no difference to the hip, like, okay? So you just need to isolate which muscle is the problem before you start releasing them, like, okay? That's the key to understand. So the deformity in the ankle can be because of the knee and can be because of the ankle itself. Is that clear?
Yes.
If you do the correct operation, the patient will walk. If you do the wrong operation, the patient will, whatever walking was doing, will stop doing that altogether. Okay. So this is easily understandable here. Okay. So if you have a hyperextended knee and a normal hip, then to match and compensate that, the heel will have to either go flat or equinus. Okay. If the heel is gone flat and the knee is hyperextended, then you know where the problem is coming from, the hip or the knee. He's just trying to give you more x-rays of the same problem, yeah? So you can see here that the person's problem is the knee, and therefore he's getting an equinus deformity for him to walk on it. Again, you can do this by asking them to sit at the edge of the bed and find out, or you can do the gait analysis for them, okay? So it's the same thing explained again. If you have a toe walker, he will have a flex knee. If you have a flat foot person, but the knee is a problem, then he will actually lift his heel to get walking again. This is just an example to understand, okay? And this is the correct line that when you ask them to stand, the center from the trochanter will pass the back of the heel on a straight leg. Whether they are flexing it or extending it, it doesn't matter. So if the problem is in the knee, they will still have the same line. If it's in the heel, it won't have the same line. So you just need to understand, you need to differentiate in the lower limb where the pathology is, okay? So what test is this?
It's Thomas test.
Very good. So this is to assess whether the deformity is in the knee or the hip. So you have assessed deformity between the ankle and the knee. Now you need to know whether deformity of the knee is flexed because the hip's a problem, or is it flexed because the knee is a problem. So if you do the Thomas test, and it's absent, then it's a knee problem. If you do a Thomas test and the knee is corrected, then it means it's a hip problem. So the contracture is the hip and the knee. Do you understand what I'm trying to explain here, yeah? You need to be 100% sure where the problem is before you correct it, because if you don't and you correct it, then it will actually get worse. And the person who was walking before your operation will not walk anymore because you have done the wrong correction. Like, okay, so that's very important in cerebral palsy. You have to isolate the problem and you have to correct it. So the mainstay of treatment in England, I'm sure it's the same in Pakistan, is we do a lot of counseling for parents. They have a lot of physiotherapy and splints made for them. Okay, there is a role of Botox in people. Instead of doing surgery, you can do Botox. And how does that help by doing Botox instead of surgery?
It relaxes the neuromuscular junctions and prevent further contracture formation.
So what it does is basically it does two things. First of all is it only in the spastic type, not in the flaccid type, but in the spastic type, if you give them a Botox and their deformity corrects because you've temporarily paralyzed them, yeah, so then you can go back and do a permanent surgical procedure. So instead of, say, correcting the knee, hamstring muscles, if you give an injection to them and the deformity corrects, then the problem was in the hamstring, and you can come back and do a surgical release. However, if you do a Botox and deformity actually get worse, then it was a good thing to do the Botox test before, because the hamstring was not the problem, it was problem the heel. So it also gives you a diagnostic effect. And if you do a certain level and repeat injection, you can actually completely destroy the neuromuscular junction, and therefore the Botox deformity is all you need rather than surgery. So again, counseling, physical therapy, bracing, testing with Botox and permanent, and surgery. And most of the surgery is going to be tenotomies and lengthening. Sometimes you need to do transfers, and occasionally you do athetosis for these patients. Okay. So you must understand that if a child does not neck hold 2 years, does not sit at 4 years, and is not walking at 8 years, he doesn't have any muscle obvious deformity, the gentleman or young lad has got cerebral palsy. Okay. So this is another thing you have to remember. If they don't do their milestones on time, then it has cerebral palsy, whether they have the deformity or not. And they are the one that comes into the mild form, like, okay. So they have to meet their targets at a certain stage. Okay. I think that's all we have on cerebral palsy. So you must understand that if somebody shows you cerebral palsy or talks to you about cerebral palsy, you have to classify it. So you need to know whether it's a one side, two side, or complete body involvement. You need to know whether the person can walk in his house, in his community, or is totally non-walker, and then you have to classify them according to which part of the brain is involved. So it's simple and easy to understand if you know how to do it systematically. Okay. Once you've done that, then you want to identify where the problem is. Once you've identified the problem, then you correct it. But most of the management for cerebral palsy patient is counseling, splints, physiotherapy, maybe do some Botox, and then do some correction and orthodesis or fusions. Do we understand that now? Can you walk through cerebral palsy the exam now?
Can you please repeat the how to separate the ankle and hip problem, or the test you told us?
Okay, so the reason that the person will have a bent knee is either the problem is in the hip, or the problem is the ankle, or the problem is in the knee.
Ankle,
okay?
right?
So if the problem is in the ankle, right? If the problem is the ankle, then you would be able to do the hamstring test by asking them to sit at the edge of the bed. And if you flex the knee, the deformity is not going to get better because the hamstring was the problem. Okay. If the deformity gets better, it's not located to the knee because the tight hamstring don't go away like it was an ankle problem. However, if it doesn't get better, then it's a knee problem. Then you need to know whether it's a hip or a knee. So you do the Thomas test. If the hip's flexed and causing a knee flexion, and therefore it's a hip problem rather than a knee problem. So if your heel is equinus, you will actually bend your knee. If your knee is bent, you will bend your hip. If your hip is bent, your knee will have to be extended, and you'll have to have an equinus deformity to walk. So you get the gait by getting the length right, whatever way you want to do it. But you have to know where the primary problem is. You have to isolate hip, knee, or ankle before you correct them.
Okay, thank you, sir.
No, you don't understand, Javed. You're just saying thank you because you just want to remember it, yeah?
No, it's a bit complicated. Yes, I know. But we have to isolate the deformity. The central idea is this: we have to isolate the deformity, and then we can proceed with the procedure.
Very good. You see, because we understand this, that if you have got an equinus deformity, your knee will bend anyway. Okay, because
yes,
you're causing it to bend. However, if you have a flex knee, the ankle will go into equinus for you to walk, because you can't do the equinus to go to walk, isn't it? And you need to know the hamstring test, and you need to know the Thomas test to tell you which is the problem, so you can isolate it if you want to go there, what you want to do with it. Okay. But if exam is they show you this cerebral palsy, they probably will be the classification they will ask you, so you can give them the geographical classification. You have to give them the ambulatory classification, and you have to do the cerebral classification. Yeah.
Yes.
So not everybody has the same problems. It is basically a constellation of various problems. Okay. So let me give you a few minutes break and a couple of minutes, and we'll come back to Gait then. Yeah. Just give me a few
Okay,
minutes.
sir.
Jama?
So they won't bring a patient for cerebral palsy in the exam because they can't. It is totally unfair for the child to be brought for the exam. But however, they will have X-rays. So they will have X-rays. Pictures. I was seeing pictures of Zahid Askar Saab on Facebook today. They were doing a talk and they had orthotics. They had a child with club feet and his shoes put on for display. So they were talking about shoes for people to wear in club feet. And there was a picture of what's that called? Public harness. So then there was a tray with all the knee replacement systems in it. Instrumentation for knee replacement. And what was the fourth thing? They had pictures of. They had pictures of polio, one side polio with person having. They didn't have a patient, but they had pictures of it. So they were doing a TOAX. Is that what you call it? TOCAS or TOCS or whatever you call them? Yeah. They were doing a mock exam. Is that how it works?
Total of 12 stations. There is either a X-ray or a clinical picture or something, just like a CP child.
Yeah.
And then we are asked 3 or 4 questions related to that problem.
Yeah, so it is not a difficult exam as such, because by now you should have prepared for the exam. I don't know how you do it, but in our part of the world, we have 4 years to become a registrar, and during that 4 years, we are taught. And then at the end of the 4th year, we do an exam which is called the FRCS Trauma North. And because in 4 years we rotate everything, we do PEDS, we do trauma, we do bone tumors, we do arthroplasty, we do arthroscopy. So the exam is related to the 4 years we spent. And when we pass the exam, we're not allowed to go and practice. We then go to do 2 years post-exam. One is a specialty related and one is a fellowship. So like when I did my exam for 1 year, I did shoulders. And the next year I did a fellowship in upper limb. So, and by the end of 6 years, then you can apply for a consultant post. So, but it's all what you see is what we do, the exams. That's why the exam is not difficult, isn't it? It is like a rukhsati, Mangni and Shadi is done. You have to have the rukhsati to go to do something more. That's what it is. The exam is all about putting the links together.
Assalamu alaikum, sir. Can you hear me?
Yes. Okay.
Hello.
Yes, I can hear you.
Yes, sir. Sufyan here, sir. It's an amazing talk that you actually discussed regarding cerebral palsy. Are there any repeaters present in this group who are actually going through the exam, the clinical exam, more than one time? Are there any people who are giving it for more than one time, the clinical exam?
So guys, Sufyan is asking you that is anybody who has done a clinical exam before?
No, sir. Most of the candidates are appearing for the first time in the exam, sir.
That's the best time to pass exam.
Yeah, you people are really lucky that you are appearing in the first in the exam, and as the exam is being modernized, cases like CP and polio are actually being sidelined slowly and gradually. We still see a lot of cases of CP and polio, and some of them are being selected as an examiner to go into the examination either as a long case or a short case in your scenario. The basic thing in identification of this type of cases is it's not, I mean, up to the level of expertise. The most commonly what they are actually they want you to identify is that you need to identify the problem and you need to actually make a plan out of it. That's the only thing that actually they are actually expecting you out of it. The gait cycle that actually Mr. Shah has actually told you in his talk was very elaborately. He has subdivided these things in the sub-classification of the gait cycle, and I think it becomes the most pivotal part of your examination where you're actually trying to see the child. Some things that I would like to add into all of this is that first, whenever you are actually trying to identify or actually make a plan out of a CP child, you need to look into the intellect of the patient as well. That what type of intellect that does the patient carry, is he or she is able to obey your command. And the second thing that you actually have to see is whenever you're trying to looking for corrections and in terms of your joints, that whether you're trying to correct the knee joint or the hip joint or the ankle joint, you need to evaluate that whether if you're going to perform a surgery in terms of lengthening or in terms of relaxation of your muscles, you need to see that whether the joint is still supple or not, or the deformity has actually made it so tight that when your patient actually comes out of the cerebral palsy phase, does it actually lead you to go into correction and all that? Well, one of the way to actually look that whether your joint is going to be supple or not is the use of buttocks that mostly slowly and gradually are being practiced in our part of the world, and it has been introduced recently, and they are being practiced successfully. Now, the second thing that you can actually do is that you examine your patient under anesthesia. When anesthesia will actually take out all your alpha fibers, we are actually firing inside your cerebral cortex, and it will actually tell you that your joint is actually either supple enough for your surgery to actually be successful. If you're planning a surgery for equinus posture of your foot, but if your joint has actually gone into a very, very stiff sort of phase, your surgery is not going to help the child. So only these two things. But as Mr. Shah has said, that this exam does become unpredictable at times, and you do tend to see a lot of patients physically being present over there with all those deformities. And I still think that these difficult topics like CP and polio needs to be discussed with the people of very senior caliber. Like I learned to examine my CP and polio from people like Professor Ghulam Mehboob and Professor Anisuddin Bhatti, who are actually very, very experienced in picking up this. So this was a little bit at that. And this thing has been discussed in quite elaborately by Mr. Shah. So if there are any questions that people would like to ask, I think the more you discuss, the better it is for your future and for your clinical exams to come.
So we have discussed this quite detailed. You know, मैंने सुफियान इनको कहा है कि अगर कोई नहीं मिले ना, तो अपने घर में माँ बाप को सुनाओ, अपनी बीवी को पकड़ो, बच्चों को पकड़ो, जो है एक टॉपिक लेके उनको सुनाना शुरू करो. The more you talk, the better you get for the exam. The crux for the CP is, the crux for the cerebral palsy patient is, you need to know that this is cerebral palsy. Okay, so there are various things. If they don't meet their landmarks, they don't meet their parameters or milestones, and it's cerebral palsy. If they have one body involved or half of it involved, you know it's cerebral palsy. Then you need to classify them according to the involvement of the body, according to their geography, and according to the involvement of the brain. Once you've done that, you've done the most difficult part. You've shown your knowledge about cerebral palsy. Then you need to analyze them and to make sure that you identify where the problem is. Is it in the knee? Is it in the hip? Or is it the ankle? I've not discussed difficult things to you, but when I was in my pediatrics rotation, we used to get a thing called windswept hip. Do you know what that means? So they used to have dislocation of one side, adduction deformity and abduction deformity. It's very common in cerebral palsy patients because they never used to turn up for their rehab, and they used to just lie in a bed, and the whole hip would go to one direction on both sides, and it used to be called the windswept deformity, wasn't it? So there's a lot of deformities you can see, and Sufyan knows, and you guys knows, that the pathology in Pakistan is a lot more severe than I have ever seen or done it. I've never seen a what do you call it, a polio patient in my life. Okay, but in Pakistan it's a common occurrence. Everybody gets to see it. So you have to practice and learn according to what it is. But for the exam, I think we've had enough information that we can survive the cerebral palsy station if you do get a cerebral palsy station. Most of the times, the person who's going to be asking you is going to be a professor on the subject. You know, if Bhattisab is asking you, or all these guys are asking you, there is no way you can know the knowledge that he has. You have to show them enough knowledge that you're safe, you can negotiate yourself. For later on learning, if you become a specialist in it, you can learn more. But the whole idea is for you to understand that the exam you have to survive and how to survive and get through it. Okay. But before I forget, after we finish Gait, we'll have an hour's break, and then Sufyan and Kazim will join in. They will talk about soft tissue needs, including multi-ligament injuries, which is very simple, but I don't know why you guys make such a big fuss out of it, like it. Okay. So are we all relaxed enough to go to Gait? I'll quickly go through this. I don't want to make it complicated for you. I just need to know the basic principles, right? And some of the definitions, unfortunately, you have to learn and remember. Should we go through it?
Yes, sir. We are ready.